Hi everyone, welcome to our module on plasma cell disorders. Before beginning with the video, I would like to request all of you to subscribe and keep supporting. This lecture series is provided free and is open access for everybody. If you find it useful and wish to support its development, you can pay us with the link that is on the screen and that's also pinned in the description. You can pay us with any of these payment methods. Now, beginning with understanding what a plasma cell disorder is. Plasma cell disorders are typically characterized by monoclonal proliferation of B lymphocytes, which have differentiated into plasma cells. So these abnormal plasma cells produce a single type of immunoglobulin, or just might be just fragments of it. This monoclonal immunoglobulin is called as an M protein, which is also called as a paraprotein. The most common types you'll see are IgG followed by IgA and sometimes just light chains, either kappa or lambda. So this concept of monoclonality is extremely important for understanding all the plasma cell disorders. Now let's try to understand the pathophysiology of plasma cell disorders, like how it develops. These neoplastic plasma cells accumulate in the bone marrow, and this leads to two major problems. The first one is suppression of normal hematopoiesis, and the second one is overproduction of a monoclonal protein. So a very high yield mechanism we can remember with relation to the pathophysiology or pathogenesis of plasma cell disorders is the RANK ligand expression. So whenever there's RANK or receptor activator of nuclear factor kappa B ligand, whenever there's appearance of that ligand, what happens when this RANK ligand is synthesized is that it just activates the osteoclasts or the bone resorpting cells, which leads to active bone resorption. And this eventually leads to more and more calcium being released into the circulation. And this leads to hypercalcemia. Now let's try to understand about multiple myeloma. So this multiple myeloma, you may have heard about it many times whenever you're in your clinics or whenever you're in clinical postings or your classes from your lecturers or professors. So this multiple myeloma is what we might have heard too many times. Multiple myeloma is the most important plasma cell disorder clinically, so it typically affects older adults over the age of 60 years. And the core pathology in this multiple myeloma is that there's malignant plasma cell proliferation in the bone marrow, and this leads to excess. So whenever there's malignant plasma cell proliferation, this is accompanied with excess monoclonal immunoglobulin production. So the most common immunoglobulin that is produced is IgG, and this is followed by IgA. So whenever you see features of Crab criteria we're going to discuss right now. So the classic presentation of multiple myeloma is summarized by using the Crab criteria. So C stands for hypercalcemia due to bone breakdown or bone resorption. R stands for renal failure, mainly from light chain deposition, and this might lead to production of this might lead to development of a myeloma kidney. A is for anemia, specifically usually normocytic anemia due to marrow infiltration, and B is for bone lesions, specifically lytic lesions, so lytic bone lesions that can lead to pathological fractures by just weakening the bone. So whenever you see hypercalcemia, renal failure, anemia, and bone lesions, you have to think about multiple myeloma. Now let's discuss about the bone and renal pathology in this multiple myeloma, how the bones and the kidneys are affected. Bone lesions in myeloma are classically described as punched out lytic lesions. So, an important exam point is that bone scans may be normal because there's no osteoblastic activity in this multiple myeloma because the bone marrow is completely infiltrated with this monoclonal proteins. This leads to reduced or null osteoblastic activity. So, in those cases, bone scan may be normal. But the characteristic appearance that we see in a multiple myeloma patient is punched out lytic lesions on X-ray. So in this image, we can easily understand and describe the characteristic punched out lytic lesions on a skull X-ray. For kidneys, light chains called Bence-Jones proteins, they combine with another protein called as a TAM Horsfall protein in the tubules, and when this Bence-Jones proteins combine with TAM Horsfall proteins, they form casts in the renal tubules, and these casts can lead to obstruction, tubular obstruction, and this leads to inflammation, and eventually this can lead to renal failure. So Bence-Jones proteins, light chain accumulation leads to uh, so these light chains are called as Bence-Jones proteins. When they combine with TAM Horsfall proteins, they just form Bence-Jones and TAM Horsfall. They combine to form casts in the renal tubules, and whenever these casts obstruct the tubular lumen, this can lead to inflammation, and this eventually can lead to renal failure. The key diagnostic test is serum protein electrophoresis, or SPEP. So it shows a sharp M spike in the gamma region. So whenever you see a question mentioning if there a sharp M spike in the gamma region, you need to think about multiple myeloma. So this is a typical feature in serum protein electrophoresis. So this represents monoclonal immunoglobulin production, and this test is used both for diagnosis and for monitoring disease progression in cases of multiple myeloma. On peripheral smear, you'll see a Rayleigh's formation. So this looks like the red blood cells are stacked like coins, one over the other. And this happens because increased serum proteins reduce the repulsion between the RBCs. So the mechanism of this Rayleigh's formation is through whenever there's increased serum proteins or whenever there's monoclonal proliferation, this leads to a reduced zeta potential between the RBCs. Or you can also describe it as it can reduce the repulsion between the RBCs, and this eventually leads to aggregation of RBCs one over the other, where they just stack up or like coins, and this is called as a characteristic Rayleigh's formation in cases of multiple myeloma. So whenever you see Rayleigh's formation on a peripheral smear in a patient with features of CRAB like hypercalcemia, renal failure, anemia, and bone lytic lesions and associated with Rayleigh's formation, you need to understand that it should definitely be a case of multiple myeloma. Now let's also discuss about urine protein electrophoresis, or UPEP. So urine protein electrophoresis is used to detect Bence-Jones proteins, which are free light chains. So a key exam point is that these urine dipsticks may be negative because they detect albumin, but not the light chains. So So this UPEP is essential for diagnosis. So you can't just decide if it's a case of multiple myeloma or not by just doing a urine dipstick, because this urine dipstick might be negative for these free light chains, and they only detect the albumin, but not the light chains. So you can't rely on standard urine dipstick for diagnosing a case of multiple myeloma, and you definitely need to do urine protein electrophoresis. The diagnostic criterion is more than 10% of clonal plasma cells in the bone marrow. Morphologically, these cells have, eccentric nuclei, clock phase chromatin, and a perinuclear clearing called a HOF. So this perinuclear clearing is characteristically called as a HOF. So these are classic findings in multiple myeloma: eccentric nucleus, clock phase chromatin, and perinuclear clearing, also called as HOF. These three are the characteristic findings on a bone marrow biopsy of a patient with multiple myeloma. There are several additional high-yield findings we need to know about. So light chains can deposit also as AL amyloid, leading to amyloidosis. And the other one is that ESR is often elevated due to high protein levels. There's also increased infection risk because normal immunoglobulins are suppressed. And patients are especially prone to infections with encapsulated organisms like Streptococcus pneumoniae. Now let's try to understand about monoclonal gammopathy of undetermined significance, which is also abbreviated as MGUS. So this MGUS is a pre-malignant condition. You will see an M protein But plasma cells are less than 10% in the bone marrow, and there are no CRAB features. So these patients are asymptomatic. So the typical case of an MGUS or monoclonal gammopathy of undetermined significance looks like there's presence of M protein or M spike at the gamma region whenever you do a serum protein electrophoresis. And the other feature is that their plasma cells are present, but they're less than 10% in the bone marrow, and CRAB features are absent. Hypercalcemia, renal failure, anemia, and lytic bone lesions. So all these features are absent. So whenever these three features are there, you need to think about MGUS. This MGUS is a pre-malignant condition and patients are usually asymptomatic. This MGUS is important because it can progress to multiple myeloma. So the risk is about 1% per year. These patients are monitored with periodic serum protein electrophoresis and no treatment is required unless progression occurs. So just symptomatic. So although already this is an asymptomatic condition, you don't just need to give any kind of treatment unless progression occurs, and we just need to do a periodic serum protein electrophoresis monitoring. Now let's discuss about Waldenström macroglobulinemia. So this is a lymphoplasmacytic lymphoma that produces monoclonal immunoglobulin M. So this IgM is a pentamer, which makes it a very, very large molecule. So this has important clinical consequences. So this Waldenström macroglobulinemia is a type of lymphoplasmacytic lymphoma, and there is production of monoclonal IgM. This IgM is a pentamer. So these are three key points we need to remember about and memorize about Waldenström macroglobulinemia. Because IgM is large, this can lead to increased blood viscosity. And whenever there's increased blood viscosity, it leads to a syndrome called as the hyperviscosity syndrome. So patients present with blurry vision, headaches, dizziness, neurological symptoms, and Raynaud's phenomenon. So whenever you see features of blurry vision, headaches, dizziness, neurological symptoms, Raynaud's phenomenon, along with absence of CRAB features, along with less than 10%, along with the production of the monoclonal IgM, you need to think about hyperviscosity syndrome. So the fundoscopy finding in a case of hyperviscosity syndrome is sausage-linked retinal veins. Whenever there are unbranched segmental or retinal veins, you need to think about a characteristic sausage-linked retinal vein appearance, as you can see in this image. Now let's try to differentiate between Waldenström and multiple Waldenström uh, microglobulinemia and multiple myeloma. Waldenström macroglobulinemia produces IgM and causes hyperviscosity, lymphadenopathy, hepatosplenomegaly. Importantly, it does not cause lytic bone lesions. In contrast, this multiple myeloma involves IgG and IgA and presence with CRAB features and lytic bone lesions. There's also involvement of bone marrow in this case of multiple myeloma, whereas in Waldenström macroglobulinemia, there are no lytic bone lesions and there's very less bone involvement. But the thing is that there's hyperviscosity syndrome where the patient has presence with dizziness, blurred vision, headaches, neurological symptoms, and something what we also call as the Raynaud's phenomenon. Now let's just try to quickly summarize the entire module in the slide. Multiple myeloma has CRAB features, lytic bone lesions, and more than 10% plasma cells. So these are the key points you need to remember about multiple myeloma. This MGUS, monoclonal gammopathy of undetermined significance, or MGUS, this has an M protein, but there are no symptoms. This MGUS patient is clearly asymptomatic, and there are less than 10% plasma cells with a 1% yearly progression risk. Waldenström macroglobulinemia produces IgM and causes hyperviscosity without any kinds of bone lesions. So the common exam traps Mm, different kinds of step exams includes whenever they can just trap you at the bone scan. So this bone scans may not always have lytic punched out lesions, and they can sometimes be negative in multiple myeloma too because there's no osteoblastic activity. This dipstick might be negative, but UPEP might be positive in cases of multiple myeloma because whenever there's multiple myeloma, there's production of light chain monoclonal proteins, and these might not be detected by dipstick because dipsticks are standardly designed to just identify and test the level of albumin in the urine. Rawlix formation is not for sickle cells, and the other point we need to remember and memorize is that hyperviscosity always points towards IgM, Waldenström macroglobulinemia, not IgG. And finally, CRAB features are specific to multiple myeloma only, no other plasma cell disorders. To summarize, plasma cell disorders involve monoclonal immunoglobulin production. Multiple myeloma presents with CRAB features, M spike on SPEP and lytic lesions. SPEP is nothing but serum protein electrophoresis. MGUS is a pre-malignant condition, and this is mostly asymptomatic. Waldenström macroglobulinemia involves IgM and hyperviscosity. The characteristic feature we need to remember about Waldenström macroglobulinemia is that there's no involvement of any kinds of lytic bone lesions. And finally, Wens-Jones proteins are light chains that cause renal damage. Whenever these Wens-Jones proteins they combine with TAM horsefall proteins, they form casts, and these casts just lead to tubular obstruction, and this finally leads to inflammation, and this eventually presents as renal failure. So I think and hope you have understood the concepts of plasma cell disorders. If you understand these concepts, you'll be able to solve most of the USMLE questions on this topic. Unfortunately, this hematology is mostly about memorizing rather than, yeah, there's a lot of concept to understand, but the key is pattern recognition. So whenever you're able to just identify and analyze patterns whenever you see questions on a Q bank or just in your real test, whenever you're able to identify patterns, you can easily solve any kinds of questions. I'll be back again, right back with the fourth video on platelet disorders. See you there. Bye.